David Leven. David is the Executive Director Emeritus and Senior Consultant of End of Life Choices New York, an organization that seeks to ensure the patients have their health care wishes honored at the end of life and that they receive quality care while not receiving unwanted care. An advocate for patients and an expert on advanced care planning, patient rights, palliative care, and end-of-life issues, including aid in dying, Mr. Leven has played a leadership role in having legislation introduced and enacted in New York to improve pain, palliative, and end-of-life care. He is a graduate of the University of Rochester and Syracuse University College of Law. David is a recipient of numerous awards, including the Westchester Civil Liberties Union Civil Liberties Award and the Public Interest Law Award of the New York State Bar Association Committee on Public Interest Law. He is a past distinguished lawyer in residence at Truro Law School. David, we look forward to your presentation.
Thank you very much, Jeff. It's good to be here on this cold morning, and the weather's going to get worse, I guess, throughout the day. But here we are. So, just a little bit more about myself. I am a lawyer by training. I actually went to law school with Joe Biden. He was a classmate of mine. Of course, he's much, much older than I am. You know, he's 77. I'm only 76. I'm going to talk about some pieces of legislation this morning, and with the hope that you as individuals will take some action, certainly with respect to the Medical Aid in Dying Act, but also on other bills. And I hope, too, that Westchester Ethical Culture Society of Westchester can also take a position on at least the Medical Aid in Dying Act. I understand that you have the authority to take positions, and occasionally you do. And in fact, the bill, the Medical Aid in Dying Act, is supported by the New York Ethical Culture Society. You should join. So how many of you eventually think you are going to die? I'm not seeing all the hands go up. Okay, well, I've done a lot of studying on this issue, and actually I have found that we have a 100% mortality rate. And so even with all of our terrific teaching hospitals in the area, with wonderful doctors and nurses and so forth, we all are eventually going to die. So the only question is how we're going to die and who's going to make the decision as to how we're going to die. So if you think about it, you actually, and you may not know this because some people still don't, even though it's been the law of the land since 1990, we all have an absolute right to make our own health care decisions, even if those decisions may result in death, as long as we have decision-making capacity. As long as we are competent to make our own health care decisions, we can say yes or no to any treatment that's offered at any time. And so if we were to need dialysis, for example, but maybe you're 90 years old and you don't want to go through with it, and you don't want to have to go 3 times a week for dialysis, you could just say no, which might result in death. If you are on a ventilator, it doesn't matter what age you are and whether you're terminally ill or not, you can say, no, I either don't want the ventilator, or you can have it withdrawn. And some doctors still have a hard time doing this, unfortunately, because too many doctors are trained at a time when medicine was pretty paternalistic in the 70s and 80s and even the 90s and even today. And so doctors have been trained to treat, and they don't always understand that it's really the right of patients to make the ultimate decision for themselves as to what treatment they're going to want or not want. And there's too much treatment that's provided today which is really unwanted and unnecessary. And there's actually a bill that addresses that topic, which I'm going to talk about in a few minutes. So first I want to talk about medical aid in dying because it is a hot topic. How many of you know what medical aid in dying is? Or anybody give a definition of it? And if not, I'll be happy to do that. You were at my last talk, so you should know. Well, it's medical assistance, but what it really entails is this. It's just another option at the end of life so that someone who is really suffering but may not be on any life-sustaining treatments can ask for a prescription of medicine from their doctor, and they can take the medicine if they so choose at a time and place of their choosing, and they do need to self-administer the medicine. So that's essentially the definition. Yes. Either by mouth, it's usually crushed medicine in a liquid form. It can be done otherwise. If you're receiving fluids intravenously, it can be done in that way as well. And it's now legal in 9 different states in the District of Columbia, including most recently in New Jersey and Maine this year. And it affects now over 20% of the nation's population, because California is also one of the states which permit it, which has almost 40 million in population. It's twice as large as New York now, believe it or not. So, I mean, at some time they'll probably become a nation of their own, especially if Donald Trump is reelected, which probably might be a wise idea for them. But in any event, I won't start with politics. Okay. So I want to just go over briefly. Well, let me just see by a show of hands. For those of you that know what, or think you know what medical aid in dying is, let me see by a show of hands how many of you support it. Okay, I'm seeing all hands go up except for the young lady who just walked in, so she hasn't been informed. So I'm just going to say a few other things about it, because I think it's important when it's being discussed with legislators or your friends or relatives. Hopefully you're going to be persuading all of these people to support medical aid in dying. But most importantly, we know that when it's an open legal practice, appropriately regulated, it's a safe, humane, ethical medical practice that benefits patients and families and causes no harm to anyone. So we have over a half-century of cumulative evidence from the states which have permitted medical aid in dying that conclusively show that the laws have worked as intended. We know, too, that medical aid in dying is not suicide, even though it's been characterized as physician-assisted suicide by opponents particularly, but by even supporters for a number of years. So why isn't it a suicide? Well, suicides, and I don't mean to demean suicide, because suicides in some cases are okay, I think, and there's a good reason why some people commit suicides. But suicides are committed by those who could live but choose to die. They're generally committed by people with mental illness, in isolation, often impulsively and by violent means. And they are tragic. But to the contrary, medical aid in dying is available only to terminally ill patients who will soon die. Their disease is what's killing them. The process usually takes several weeks and occurs always after consultation with 2 physicians and almost always with family support, and it is empowering for patients and their families. And a recent statement by the American Association of Suicidology entitled "Suicide is Not the Same as Physician Aid in Dying" makes 15 different points of distinction between medical aid in dying and suicide. And a number of organizations have rejected the term physician-assisted suicide, including the American Public Health Association, the American Medical Women's Association, which is more advanced than the American Medical Association, the American Medical Student Association, and a number of other organizations. So there are a few other things that we know about medical aid in dying. There's no evidence that it disproportionately impacts any vulnerable populations, whether the elderly, the poor, people with disabilities, people of color. There is no evidence of coercion or abuse of people with disabilities or anybody else. And we also know that people who access medical aid in dying have at least as good, if not better, deaths than those who die by other means. We know, too, that while hospice is excellent and really provides high-quality care, generally speaking, and relieves the suffering of the vast majority of those who are dying, it can't relieve the suffering of all the dying. And we know this because over 90% of those in Oregon, which has had an aid in dying law since 1997, are actually receiving the best quality end-of-life care in hospice. We know, too, that people haven't been rushing to take the prescribed medicines. It's only used in about 1 in 250 deaths, or 4 out of 1,000. But it's of great comfort to thousands of people who know that they have this option available to them. And finally, we know that none of the problems that opponents have feared have emerged, and there are no longer any legitimate arguments that can be made against medical aid in dying. So, we have too many people who are still dying unnecessarily with great suffering, and they should have this option available to them. And so, as Governor Cuomo said just a few months ago, pass the bill. All right, so let me just tell you what's going on with the bill. It's in the state legislature. By the way, the lead sponsor of the bill is in the Assembly is Amy Paulin. She's my Assembly person. She's based in Scarsdale. She covers parts of, I think, White Plains, actually, as well as Scarsdale, New Rochelle, and Pelham. And I went to her 5 years ago to ask her to sponsor the bill. And she did, and so she's the lead sponsor. And Dick Godfrey, who is the chair of the Assembly Health Committee, is a co-sponsor. And there are now about 36 sponsors in the state assembly out of a total membership of about 150. But that's a pretty good number. In the state Senate, the bill was introduced by Senator Diane Savino, who covers Staten Island and parts of Brooklyn. And she was also a lead sponsor of the medical marijuana bill. And she has been terrific on the Senate side. And initially, there was only her as a sponsor, and that was because the bill wasn't going to go anywhere until the Democrats took over the Senate last year. And now with the Democrats in control of the Senate by a 40 to 23 margin, there are now 12 sponsors of the bill in the Senate, including some of the newest members of the Senate, including my state senator, Alexandra Biaggi. So I think we really have a chance of moving the bill relatively soon, but we still have problems. There are a couple of we need 2 more members of the Assembly Health Committee to come out and support, because even though most Democrats on the Assembly Health Committee support the bill, all Republicans oppose it, and some Democrats still oppose it. So it's really important to be out there and to be advocates for this bill with your legislators. I know Alex didn't make it here today, right? He was going to bring some documents. I don't know if he sent you any documents. If you got, okay, so you got this guide to medical aid and dying advocacy, and I hope you've all taken a look at it. If you haven't, please do so. It has a summary of the bills, which are identical in both houses, and it talks about how you can go about advocating for this bill with your legislators. And one of the easiest things you can do, there are postcards in the back of the room. Pick up a postcard, send it to your legislator, and it doesn't make a difference even if they're a sponsor of the bill, because what we need to do is to get people really excited about it and to have it as a priority for them. The fact that they're a sponsor doesn't mean anything unless at some point the Senate Majority Leader and the Assembly Speaker say that the bills can move out of committees and onto the floor of their individual houses. And I'll tell you, unfortunately, Senator Andrea Stewart Cousins, who I believe is going to come out in support of the bill eventually, has still not done so. And I've talked with her a number of times. We've talked with her staff. Her staff seems very supportive. I think she's just been very cautious. And maybe one of the reasons is last year, or this year actually, earlier in the year, a number of very progressive health care bills were passed by the state legislature, and some of those bills really annoyed the New York State Catholic Conference and some Orthodox Jewish groups and so forth, and so they said, well, enough is enough, let's wait till at least in January before we start to move bills like the Medical Aid and Dying Act. The same with the Speaker of the Assembly. He has not taken a position on the bill. We need their support. I didn't mention in the Senate, the chair of the Senate Health Committee is also a supporter and is now a sponsor of the bill as well. We met with him just a few weeks ago, Gustavo Rivera in the Bronx, and he's terrific. And I think he's going to really have this bill as a priority in his Health Committee. But again, all legislators need to come on board, and for those that are sponsors, they need to get really enthusiastic about it. So please send postcards, have meetings with your state legislators if you can do that. That's the best thing to do. Sometimes you don't always meet with them when you want to. You set up a meeting and then you meet with staff instead, and that happens to me too. I mean, I've been working in the state legislature for some 40 years, since I started with Prisoners Legal Services in 1979. I was just telling Phyllis that this past week was my 40th anniversary of my starting date at Prisoners Legal Services of New York, which is where I worked for 20 years. It's not, you don't always meet with the legislature, but the staff, key staff are important to meet with because they have a lot of influence with the legislators, and they will take the information that you provide them. Okay, so any questions at this point on the Medical Aid in Dying Act and some of the things you might do with your state legislators? In terms of the medicine, administering the medicine? Okay, well, it's a process. First of all, there's lots of components to the whole process of medical aid in dying, where you do need to have 2 doctors confirm that you are terminally ill and that you're mentally competent. And then one of those doctors, if you go through the process, you make a written request. You don't have to make a written request for any other way of dying, but for this way you do. It has to be signed by 2 witnesses. And then you get the prescribed medicines, and somebody has to pick them up at the pharmacy. It can be the person who's dying, probably not, probably a relative or a friend. And then it's usually mixed up, and there's different medicines which are involved. It's the ones that kill you, there are sedatives, there are things that make sure you're not going to regurgitate, you're not going to throw up. But there are protocols, and those protocols have been tested over many years. It's not always easy to get some of the medications, and they are not cheap either. But on the other hand, even if they might cost $2,000 to $3,000, if you think about end-of-life care and how much that might cost ultimately, even if you might be in hospice, that can cost a whole lot more out of pocket ultimately than getting these medications. We don't know how it's going to work in New York, whether Medicaid's going to cover it. Medicare can't. There's federal law which prohibits Medicare from funding what they consider to be suicide medications. But Medicaid does cover it in Oregon. It doesn't cover it in Washington, but in the state of Washington, there is a foundation which helps people who can't afford the medications. California, Medicaid is covering it, I believe. So we don't, but I know that Dick Godfrey, the chair of the Assembly Health Committee, wants to have Medicaid covered in New York, but he doesn't want to put it into the bill. So we'll see what happens there. But you need to have. It's a good idea to have obviously family members or somebody present who knows what they're doing. Sometimes a doctor can be there, but he or she doesn't have to be, or a nurse. If a person's in hospice, you might want to ask the person, a nurse or the doctor, to be present at the time that the medications are taken. And I'll tell you, the medications work pretty quickly, the best ones. You can be unconscious within several minutes and actually die within a half hour. Yes, sir. Yeah, there are. Final Exit, yes, by Derek Humphrey. Well, because the method that he espouses primarily, aside from medications, is using a helium bag, and and that's fine if that's what people want to do. Again, it's not legal to help anybody in New York right now, and you could be charged with assisting a suicide because there's still the ban on suicides, which. And again, there's an interrelationship here, so the laws are going to have to be amended, different laws, if we get this law changed to ensure that there will be no problem. And actually, the bill says that this is not to be considered a suicide or a mercy killing or euthanasia and so forth. But there are the other methods, as you suggested. The helium method primarily, and people do use that. Many people are uncomfortable with it. My organization is not comfortable with it, frankly, and because. If I help you? And then you use the helium method? No, because the law only pertains to prescribed medications. So it would not be, that's not to say that you would necessarily be convicted and go to jail or prison, because very few people have actually been incarcerated for helping someone who was really in need of help, and they were just doing what they thought was right as a compassionate person. And even a doctor in Rochester, Timothy Quill, who brought a case that went to the Supreme Court and lost, trying to establish the right to medical aid in dying, under the federal Constitution, he helped one of his patients die, and he wrote about it in the New England Journal of Medicine. And after it was published, the district attorney in Monroe County, who I'm from Rochester. I didn't know Tim Quill at the time, but I knew the district attorney. He tried to prosecute Tim Quill. It went to a grand jury, and so the grand jury was asked to find that to indict Timothy Quill on the basis that he committed assisted suicide. What do you think the grand jury did? Do you think they indicted him or not? How many think they indicted him? How many of you think he was indicted? No. How many of you, okay. How many of you think he wasn't indicted? Yeah, he wasn't. And he testified himself. And I think what happened there was that the grand jury saw that this was a very compassionate doctor who was trying to do what was right for his patient, who was dying in any event and was really suffering a lot. And he just thought that he had an ethical obligation to help her, and that's what he did. So, and he's still around, by the way. He was the head of palliative care at the University of Rochester Medical Center, very highly respected doctor. Yes, sir?
Yeah, I think you said one of the requirements is family consent for treatment.
If I did, I didn't mean to say that families had to consent in any way. Families, in the bill, it's recommended that family members be notified, and generally speaking, what happens in situations like this is that family members want to keep the patient alive. They don't want to see their patient die, quote, prematurely. But eventually, most family members are brought around, and so ultimately, of course, it's the patient's decision, right? The patient has decision-making capacity. He or she can take the medications if that person decides to do so. There's no requirement that the family agree with the patient's decision. And there will be family members who won't agree. You know, the person who comes in from California who hasn't seen their sister in 25 years and now says, oh, no, we can't let her die like this. It's the same with withdrawing life-sustaining treatment. It happens all the time. There are conflicts that arise because the patient is ready to die. Other family members who are close understand what the patient's going through, and they're willing to have the patient withdraw the ventilator or whatever. And now the long-lost brother comes in and says, oh, no, we can't do this. And so you have this conflict, and then it has to go to the ethics committee, and I mean, ultimately, patients usually prevail, even though someone is objecting, because it's the patient's decision. And even in the case where the patient doesn't have capacity, the healthcare agent, of course, can make decisions for the patient by substituted judgment, meaning that the person is acting on the patient's behalf, knowing what the patient's wishes are, or acting in their best interest. Yes, back there.
That's
Yeah.
where I was going to go.
Yeah.
Because I'm a social worker, I've worked in healthcare and geriatrics for years. And, more and more people are having living wills, which I think are absolutely invaluable to the family, to write in writing what your wishes are, not just word of mouth.
Right.
But also, and my question, and I think you answered it actually, if a person has a designated healthcare crossing, here again, we see that kind of thing, like hydration and nutrition, which has to be specified in healthcare crossing.
For now, I'm going to talk about that. Yeah.
But in these states where the physician-assisted dying
Mhm.
if that's in, say, your living will or your healthcare crossing, because if you don't have capacity and healthcare crossing is making a decision, can that decision be made?
No. The person has to have decision-making capacity at the time that they ask for the medication, and no one can ask for the medication for that person. So this, for now maybe that'll change in the decades. Pardon?
If the patient doesn't have capacity
No, it doesn't matter.
And the healthcare proxy and all that.
No,
The healthcare proxy can't make that decision.
the healthcare proxy cannot, the agent cannot make. Right, but so let's talk about that next. Although I do want to say one more thing about how you can communicate with legislators. You can also send them letters, of course. You can also call and just say, I support this bill, just so they get an idea that there is support out there for a particular bill, and get your friends and relatives to do the same things. So if 20 people are calling and saying they support the Medical Aid in Dying Act, that'll have some influence on the legislative staff who is going to say, hey, legislator, in the last couple of weeks I've gotten 20 calls from people in your district saying that they support the Medical Aid in Dying Act. Okay, so with regard to decision making, and I'm glad you've raised the topic because this is something that we're working on, but there's not a specific bill yet. There is a bill, it needs to be amended, so until it's amended, I can't really tell you what to do with it, but I'm going to tell you what it's about, because it's really important, having to do with decision making for people who no longer have decision-making capacity, so someone else is making decisions for them. Right now, the law in New York State is that you can make any decision for someone based on your knowledge of what they would want or in their best interest. For example, with regard to a ventilator or pacemaker or dialysis or antibiotics. But when it comes to nutrition and hydration, as you stated, the healthcare agent now, according to New York State law, needs to reasonably know what the person's wishes are, and they can't make a decision based on what they think are the best interests of the patient. Now, to me, that's just wrong, and I've been talking with a bunch of colleagues over the last 6 or 8 months or so about this as we've come out with an advanced dementia directive, which I have a description of back there. And, well, what do you do about a person who now has advanced dementia, and they have indicated in a healthcare, in a living will type document, or which is given to their healthcare agent, that they would not want to be fed either artificially or even hand-fed if they had advanced dementia and if they were under certain circumstances. They would never want to be fed. They'd only want to be given palliative care, or they would only want to be hand-fed if it looked like they were still enjoying the food and they were not rejecting it, and they seemed relatively content with their life circumstances, even though, again, this is going to be a person who really doesn't have capacity to do much of anything. They're bedridden. Everything has to be done for them. So then we started thinking, well, why should the law be any different with regard to nutrition and hydration than it is for a ventilator or for antibiotics or for dialysis? So we're working on trying to get the healthcare proxy law amended so that it will give healthcare agents the authority to make any decisions with regard to nutrition and hydration, whether it's artificial or not, either in accordance with the person's stated wishes or in their best interests. And I think this will be a monumental step forward, frankly, because there are so many people who are getting either artificial nutrition and hydration when they shouldn't be and wouldn't want it but never express their wishes, or even being hand-fed, especially when they have advanced dementia, against their wishes. And by the way, this is an important issue because more and more people are suffering from dementia as we live a little bit longer. 40% of people over 85 will have dementia of some type. So right now, even in New York, we probably have 200,000 people that have dementia, about 6 million people across the country. So this is really important. I will communicate with you folks again later about this as the bill is actually amended. There is a bill which goes part of the way, but not all the way that we need to have it go. But the Assemblywoman, Linda Rosenthal, who's in Manhattan Assemblywoman, who's also a sponsor of the Medical Aid in Dying Act, is going to amend a bill that she submitted earlier this year to make sure, hopefully, that that there will be the provision that we want in the bill, which makes it clear that all decisions regarding nutrition and hydration can be made by a healthcare agent. I don't know if the bill will go anywhere. It's going to be a tough hoe because I will guarantee you the New York State Catholic Conference will be opposed to it. And there will be others that will be opposed to it. I don't know what the position of the Medical Society of the State of New York will be, and that's important because they do have influence. So one other thing that I just want to, again, reemphasize in terms of the Medical Aid in Dying Act or any other piece of legislation that we're talking about now or in the future is that this society should take a position in support. I don't see any reason why it shouldn't. The New York Society for Ethical Culture has taken a position in support. There are many other organizations across the state which are supporting the Medical Aid in Dying Act. And if you look at the guide, you'll see that there are numerous organizations, and they include the New York Civil Liberties Union, the New York State Senior Action Council. There are doctors who support the Medical Aid in Dying Act according to a poll by a 2-to-1 margin, by a 3-to-1 margin in New York State. And the New York State Academy of Family Physicians supports Medical Aid in Dying, the Medical Aid in Dying Act, even though the State Medical Society is still on record as being opposed, but they've been sort of reconsidering the issue over the past couple of years. We also need, you said you're a social worker, right? Yeah, it would be nice if we had State Association, National Association of Social Workers, New York State chapter taking a position. You're no longer active? Okay. Get active again. Okay, I'm going to talk about just one or two other bills and then open it up for any other questions or discussion. There is a bill that's sponsored by Assemblyman Gottfried, the chair of the Assembly Health Committee, and I think it's going to be sponsored in the Senate by the new chair of the Senate Health Committee, Gustavo Rivera. The old chair of the Health Committee, a Republican, Campanin, who was ousted in the last election, did not sponsor the bill. And this is an important bill, too, because as I mentioned earlier, too many people at the end of their lives are getting unwanted, unnecessary care. And this happens even sometimes when there's a do not resuscitate order. There was a case in New York, arising out of Jamaica Hospital. There was this poor guy who was 85 years old, and he was dying, and he had a do not resuscitate order in his file. He stopped breathing, and guess what? They resuscitated him. It happened a second time. He was resuscitated again, and the family members, after the guy died, several weeks later, and with suffering, brought a lawsuit, and they sought damages against the doctor and the hospital, and they lost. They lost in state Supreme Court, our lowest trial court in New York, and they lost in the appellate division of state Supreme Court. The case was then appealed to our highest state court, the Court of Appeals, and while it was pending, a settlement agreement was reached. And my guess is the family got a lot of money, but I don't know what it was because it's a confidential settlement. I've talked with a lawyer about it, she just can't say really. So I went to Assemblyman Gottfried some years ago to ask him to sponsor this bill, where it would make clear that people have a right to sue for damages if they have been provided unwanted care, or their family members could sue on their behalf. And they could be awarded damages up to $2,000 a day or whatever a judge thought was reasonable for continued living. Because what happened in the appellate division of state Supreme Court was that the court ruled that there is no cause of action, no legitimate lawsuit can be brought for wrongful living. I mean, really terrible decision by both courts, the lower court and appellate division. So this would sort of reverse those decisions by legislation, and it would also make very clear that hospitals and healthcare providers would not be able to recover any costs for the provision of care that they provided when that care was unwanted. Because why should anybody have to pay for care or treatment that's unwanted, right? It's not clear now according to state law. So this is another bill which I think was sent to all of you by Alex. And so again, contact your state legislators, tell them that you support this bill. Do you all know who your state legislators are, by the way? Your assembly person and your state senator? Okay, hopefully you do. And if you don't know, you can go to online to the New York State Senate website or the New York State Assembly website, and there you can find out who your own state legislator is. And you can also go to our website at End of Life Choices New York to do so as well. So I think I'll stop here, but I do want to mention that our End of Life Choices New York has a free counseling program, and we have a PhD nurse who is our clinical director, and she's been doing counseling of people who have issues about end-of-life care, whether it concerns pain management or palliative care or hospice, or people's rights to have life-sustaining treatment withdrawn, or voluntarily stopping eating and drinking, by the way, which is another way in which people can die, especially if they are near the end of their lives, and while medical aid in dying is not legal, and it's a pretty reasonable way for people to die. People have, generally speaking, have pretty good deaths. They become unconscious after a few days, die after 10 to 14 days, and Judy has worked with a lot of people on voluntarily stopping eating and drinking. So that, and our services are all free, so you should take advantage. If you have a relative, friend, for yourselves, if and when, contact Judy Schwartz, and we have a sheet out there which gives you information about our counseling service and what Judy can do on your behalf or for your friends or relatives. And she has really helped hundreds and hundreds of people, but she's not contacted nearly often enough, and I'm not sure, I don't know why. People think they can get through this themselves, and these are really difficult situations when family members are dying, or if and when you might be dying, and are hopefully in hospice care, which almost everybody should be. But by the way, let me just say one other thing about hospice really quickly. Well, hospice is generally speaking excellent, great quality of care by a team, interdisciplinary team, doctor, nurse, social worker, a chaplain, all kinds of therapists, volunteers. It's really, really good. Across the country, still only about less than 50% of people who die are enrolled in hospice, and in New York, it's only about 30%. And doctors aren't telling their patients about it because they want to keep control. And patients, yes, yes, yes.
And even the family won't make the decision until 24 hours before the patient actually dies.
And yeah, it is crazy. So you're absolutely right, and I know the statistics on this. About 1/3 of patients are in hospice for a week or less, and another third are in hospice for a month or less, even though you're eligible if you have been diagnosed with a terminal illness, which means that you are reasonably likely to die within 6 months. And actually, if you have private health insurance, you can get in hospice for 12 months in New York State, which is unusual, and I don't think anybody takes advantage of it. But so think about that. Hospice is really, really good, but it's not used nearly as often as it should be. Yeah, Phyllis. Yeah. 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 Somebody had their, yeah.
Because our organization is what it is, I'd like to hear you describe the ethical conversation that goes on in introducing these bills of legislation. What's the ethics of it?
For me, it's really about patient autonomy and self-determination and independence in terms of how we die and how we live until we take our very last breaths. And it's really about the right of patients, because I think that's the most important ethical principle. There are others that are used, beneficence and preservation of life. Well, at some point, life isn't worth preserving anymore, at least in accordance with a person's own wishes. And if they have decision-making capacity, they should be able to make any decision for themselves, regardless of whether it's going to result in death or not. And if they have expressed their wishes to someone else, that person should be able to carry out the patient's wishes, except for with regard to medical aid in dying, at least for now. And we'll see what happens over the coming decades. But it's difficult enough to get medical aid in dying bills enacted. We only have 9 states over the last 20 years that have enacted, and those are in states which are controlled primarily by Democratic state legislatures, or where Democrats outnumber Republicans in the voting populace, where bills have been enacted by ballot initiative. But again, the primary principle for me, ethical principle, is autonomy, self-determination, and independence in terms of, and privacy as well. These are private decisions that people should be able to make for themselves. Yes, sir. Okay. Yes. Well, what Jack Kevorkian was doing was he had this machine set up which would deliver life-ending medications to patients who would actually press the button to end their own lives. And he was actually, on 2 or 3 occasions, he was tried, and he was acquitted every time until he actually did it himself, where a patient couldn't do it, and then he was convicted of assisted suicide, and that's why he served a term in prison. So I have mixed feelings about Jack Kevorkian. I think he raised the issue, which was important to have it publicized so that there was more social awareness and increased discussion about end-of-life decision-making and whether or not we had the right to end our lives by taking medications. At the same time, he went about doing it the wrong way, especially the last time, probably because there was a lot of opposition to what he was doing, and especially by the Catholic Church. And he was a pathologist. He wasn't and there was no process really in terms of decision making as to whether or not the person had decision making capacity. And I think there's too much process, by the way, far too much in the bills. And the only reason there's all this process in the bills is so we can get them enacted. I mean, why shouldn't you be able to go to your doctor when you're terminally ill and say, "Doctor, I'm not on any life-sustaining treatment, but I want to end my life. Would you please prescribe medications for me?" And if the doctor is convinced that you've got decision-making capacity, why shouldn't he or she be able to just prescribe medications as a matter of standard of care and best medical practice? Why do you have to go through all this process? You don't have to do it. Now, that's not to say there shouldn't be some kind of process to make sure that you can't do anything more to improve the person's quality of life. You do want to ask a bunch of questions, just like you would with a person who wants to have a ventilator withdrawn. You want to say, what can we do, if anything, to help improve your quality of life? Are you depressed? Are you anxious? Are you suffering from pain? Or is anything else going on? Do you need some spiritual help that we can give you? And so is there anything we can possibly do to improve your quality of life so that you don't want to prematurely end your life? And that should be the case, of course, with medical aid and dying. But to go through all this process with a written request and witnesses, well, we do it because it's politically necessary, and that's the way it's been done in every other state.
Martinez will be our last question.
No, because they can't get the medications unless they have decision-making capacity. But if you have early dementia, and you still have enough capacity to make decisions for yourself in states which allow medical aid in dying, as long as you are also terminally ill, suffering a terminal illness from another disease, not the dementia, because even though dementia is terminal, at an early stage, of course, it's not terminal. You're not going to die within 6 months of dementia or dementia-connected diseases. But if you're dying from some other disease, yeah, you can still make that decision. But what some people have done, again, when they have early onset dementia, they have decided they don't want to go through what they know it's going to happen to them over the coming years, and so they voluntarily stop eating and drinking, and that's something which they can do to end their lives at a time when they still have decision-making capacity. Well, it's tough, but you know what? Pardon? Yeah, but you know what? If you're near the end of your life, or relatively near the end of your life, even if you're not because you have early onset dementia and nothing else is going on with it, but for most people who actually end their lives by voluntarily stopping eating and drinking, you've lost your appetite for the most part anyway. You do have your thirst, and that maintains, and it's really, you have to have a consistent, determined, you have to have a lot of determination, because you're going to be thirsty for the first few days, even though your mouth can be kept moist and your lips and so forth. But it's not easy to go through the process, but people do it. If you have enough determination, you're ready to go, you've had enough, life is terrible as far as you're concerned, people do it. Thank you very much.
Thank you, David. Thank you, David.